Hello guys, welcome to my YouTube channel. I am Denmark Aranas, a postgraduate medical intern, and I basically provide informative videos to medical students, and also I would like to give aspiring Filipino physicians an idea of what a medical student usually tackles in med school. If you find these videos helpful, please don't forget to hit the like button and subscribe to my YouTube channel to be updated. Click the notification bell where I'll be posting new videos every week. This video is part of my History and PE series. So for today, our topic is the Obstetrics and Gynecology History Taking and Physical Exam. There is a different approach for pregnant patients and patients with gynecologic complaints. This would be an overview of the proper interaction to these set of patients. Here now is the topic outline. First, I will discuss the history taking, then proceed with the PE. And under it would be the Lupol's maneuver and the pelvic examination. Okay, let's start. So what you see here is the usual adult history components that we use in general. Here now is what we use in OB-GYN. As you can see, there is an additional of two components, the prenatal history and the OB-GYN history. These are essential parts of the history for pregnant women and women with gynecologic illnesses. In this discussion, I will just be highlighting the main differences. As for HPI, these four components should be included in the HPI: the last menstrual period or the LMP, the past menstrual period or the PMP, the age of gestation or AOG, the expected date of confinement or EDC. I highlighted in red the LMP because this is a very important component wherein we base the computation of AOG and EDC. And you have to take note that these four components are for pregnant patients. So these four components should be present in the HPI for pregnant patients. Here now is the computation of the age of gestation. First, we have to determine the last menstrual period, and this is the first day of the last menstrual period of the patient. And then after that, we have to take note the current date for prenatal checkup. And also take note if the year is a leap year or not. And then after that, we add up the number of days for all the succeeding months until the current date of prenatal checkup. And as a tip, you should use your knuckles to remember how many days each month has, as shown in this picture. So the bony part would be those having 31. So January has a 31 days, while February it's either 28 or 29. And for those in the depression, it's 30, like here. For April and June, they are 30. So just remember the bony part is for 31 and the depression is for 30 days. Okay? Then after that, to get the number of weeks, we divide the sum total of days with 7. And the remainder would be the days. So here's an example. Let's say the last menstrual period of the patient that we have is February 1, 2020. And today is the current date of prenatal checkup. Today is June 9, 2020. And year 2020 is a leap year. So there are 29 days for February. We will be adding the number of days for the succeeding months from February to June. So as you can see here, for the month of February, we have 28 days because we subtract the total number of days for February minus the LMP. And our LMP is Feb 1. So 29 minus 1. So that's 28 days for the month of February. And if you would remember, March was on the bony part of our knuckle, so it has 31. Then April on the depressed part of our knuckle, so 30. May on the bony, 31. And today, the date is 9. So 9 days for June. So we add all this up, and that would total to 129 days. And then we divide it to 7, so we would get 18 weeks. And the remainder would be 3 days. So the age of gestation is 18 weeks and 3 days AOG approximately. Next is the expected date of confinement. We compute this using the Nagel's rule, wherein we subtract 3 months and then add 7 days and then add 1 year from the LMP. You see, it is very important that you get the correct LMP of the patient because that would determine the correct age of gestation and expected date of confinement. So here is an example. Let's say our LMP is May 10, 2020, and we would get the expected date of confinement. May is equivalent to 5, and we would subtract it with 3 minus 3 months, so we get 2. Then for the days, it's 10 plus 7, we get 17. And then 2020, add another 1 year, so 2021. So our expected date of confinement would be February 17, 2021. However, there are some modifications to this Nagel's rule, especially for the months of January, February, and March. Here is an example for the month of February, wherein we add additional 12 months to the equivalent number of the month. Like, for example, for February, it's 2, we add 12. Then that way, we will be able to subtract 3 months, and that is equivalent to 11. And then we still do the same, add 7 days, 29 plus 7, so 36. But then we no longer add plus 1 year, okay? So these are the modifications for January, February, and March. You add 12 months to the equivalent month, and then you no longer add another year. So you can see here the expected date of confinement we got is November 36, 2020. So is that even possible? Do we have 36 days for November? Of course not. We only have 30 days. So the extra 6 days would be for the next month. So our true or correct expected date of confinement is December 6, 2020. Okay, got that? And after the HPI, the prenatal history. Here we ask the cognizance of pregnancy and what age of gestation did the mother became aware of her pregnancy. And then if she used a pregnancy test to confirm the pregnancy, and if the pregnancy is planned or unplanned, wanted or unwanted. And as for the prenatal care, when was it initiated? At what age of gestation? Where? At a health center or a private clinic? And what were the procedures done to the mother at the prenatal care? Did she get urinalysis or complete blood count or ultrasound? So all of those data should be asked in the prenatal history, especially for pregnant patients. Next is the OBGYN history. It is composed of 4 parts: the menstrual history, OB score, gyne history, and sexual history. Please remember the mnemonic MOGS and associate it to the Philippine Obstetrical and Gynecologic Society. So OB/GYN history is composed of MOGS. And to remember that, POGS is for MOGS. So let's go first to the menstrual history. Menstrual history has a mnemonic too, and that is MIDAS, which stands for menarche. Menarche is the age of onset of the first mens of our patient. I is for interval, D is for duration, A is for the amount or the number of pads used for the entire cycle, and the associated symptoms like dysmenorrhea. Here are the normal menstrual parameters that you should take note, and you could use this as a reference. Let's now go to the next part of OB/GYN history, which is the OB score. As for OB score, we also have another mnemonic, the GPT-PAL. You can see here. G stands for gravida, and this is the number of pregnancies in total regardless of outcome. Okay, take note of that. While P is for para or parity. This is the number of pregnancies that has reached the age of viability. And age of viability is at greater than 20 weeks. Okay. Next is T for term. This is the number of full term births, which is equivalent to greater than or equal to 37 weeks. P is for preterm or premature births. Okay, that is 20 to 36 weeks. A is for abortion that happens less than 20 weeks. And L is for living. This is the number of children that is alive. Okay, so we have to take note that GP is for the number of pregnancies and TPAL is for the births. Okay, for full-term birth or preterm birth or if there is an abortion and currently alive children. Okay, so here is a case for an example. We have a 27-year-old female who is currently 16 weeks pregnant. She has 2-year-old twins that were born at 39 weeks gestation and a 5-year-old who was born at 40 weeks gestation. And she had no history of miscarriage or abortion. So for the gravida, our patient had a total of 3 pregnancies from the current pregnancy and from her twins and the 5-year-old. You have to take note that for twins, that is considered only 1 pregnancy. Okay, and for parity, as you can see here, greater than 20 weeks, we have 39 and 40. So parity is 2. As for the full-term births, the mother gave birth 3 times to 3 full-term babies, the 2 twins and the 5-year-old child. So term births are 3. And there are no preterm births, so 0. And there is no history of miscarriage of or abortion, so 0. And there is 3 living children in the family. So the OB score of our patient is G3P23003. Okay, so that's GP TPAL. Okay, remember that. As for the gynecologic history, here are the components. We ask about the gynecologic illnesses, like if there is a noted discharge of the patient or previous diagnosis of sexually transmitted infections. And then next would be gynae operations like um, hysterectomy or bilateral tubal ligation. And hormonal therapy, especially for those who are elderly, uh, receiving estrogen as a hormonal supplement. And family planning, if the patient uses pills or condoms or any form of family planning, we should ask that, especially if they have an intrauterine device. Uh, okay. And then if ever they had any pap smear before, and what is the result of that? Then lastly, if they were able to secure HPV vaccination. Okay. Next is the sexual history. And here are the components. We ask about this sensitive topic. So you have to tell and explain the importance of this questioning. Okay? Because this is a very sensitive topic. You'll be asking Koitar the age of first contact of the patient, and then the subsequent contacts, how many, and then the number of sex partners the patient is currently having, and then the date or when was the last sexual contact, and even the partner's sexual history if the patient is aware of it. Okay, so let's recap. OB-GYN history is composed of MOGS, the menstrual, OB score, gynae history, and sexual history. While menstrual history is composed of MIDAS, the menarche, interval, duration, amount, and symptoms. And then OB score composed of GP TPAL, G for gravida, P for para, T for term, P for preterm, A for abortion, and L for leaving, and the rest. We will now go to the OB-GYN PE. Okay, here we have the Lupol's maneuver. This is done at 24 weeks AOG when the fetal parts are more prominent and we will be able to palpate it. We do this to determine the orientation of the fetus relative to the mother. Here, as you can see in this picture, we do 4 maneuvers and we go through each one by one. Here at the pointer is the first maneuver, Leupold maneuver 1, which is called the fundal grip. This is done to determine what occupies the fetal pole or what occupies the fundus, which part of the fetal pole. Is it the butt or the head? We use our tips of the fingers of both hands to palpate the fundus. If we would palpate a firm, hard, and round mass, then that would be the head. But if it is less well defined and moves in conjunction with the body, then that's the breech, the butt of the fetus. Next maneuver would be the umbilical grip. This is done to determine the fetal part present on the left or right maternal side. As you can see in this picture, we place our palms on either side of the abdomen of the mother, and then we push the left maternal side towards the right with deep pressure, and we ascertain the part on that area. And we would determine the fetal back on either left or right side if it is smooth, hard, and resistant surface. However, if there are irregular nodulations, that represents the fetal small parts. Okay. The next maneuver is the Pollick's grip. This is used to determine the mobility of the presenting part, if it is ballotable or non-ballotable. We use the thumb, as you can see in this picture, and the fingers of one hand at the lower portion of the maternal abdomen, just above the symphysis pubis, to determine the presenting part of the fetus. If the presenting part moves upward, then the fetus is not engaged. Okay. And then lastly, uh, we change our position here. As you can see in this first three maneuvers, we are facing the mother's head. And as for the fourth maneuver, we'll be facing the patient's feet. The fourth maneuver is called the pelvic grip. And this is used to determine the attitude of the fetus, if it is either flexion or extension, by palpating the cephalic prominence. Okay, we use the tips of our finger of each hand, applying deep pressure in the direction of the axis of pelvic inlet. And where our hand would be arrested first, then that would be the cephalic prominence. Okay, so remember this Leopold's maneuver. First is the fundal grip, second, the umbilical grip, third, the Pollick's grip, and lastly, the pelvic grip. So in your OSCE, it is important to know the significance of each maneuver and the procedure of how it is done, and the expected findings should also be reported properly. Next, as for the pelvic examination, it is composed of three components: the speculum examination, bimanual examination, and the recto-vaginal examination. Okay, here are the initial steps of pelvic exam. We have another mnemonic: A, B, C, D, E, F, G. A for abdominal examination should be done previously, and then B, we ask the patient to empty her bladder, okay? And then for C, we ask for informed consent and clean the area to be examined. D, apply proper draping. E, ensure enough lighting by either using a drop light or perilight. And F, G, we will be using gloves in examining the parts of the patient, and we will be using lubricant. Here now is a mnemonic for the proper sequence of doing pelvic examination. That is VV-KUWA. V for vulva and vagina, C for cervix, U, uterus, and the adnexe. Okay. So, uh, before the speculum examination, we should first do vulvar inspection. We inspect first the external genitalia of the patient. We check for the hair distribution of the patient. It should be an inverted triangle. Okay. We also check for scars or lesions or discharge and even infestation. Okay. And then after that, we could now proceed with the speculum examination. And we often use a metal speculum. So it being a metal, expect it to be cold. So we have to lubricate the metal speculum using warm water. Okay, warm water. We do not use KY jelly because if we would want to take samples for pap smear, and then the KY jelly would contaminate the sample. So what is proper to use is the warm water only, so that we would be able to uh, avoid our patient to be feeling uncomfortable. And what should you expect to see upon speculum examination? Here, for a nulliparous patient or patients that did not have any pregnancy before, it would be a pinpoint cervical os, while for those parus or patients who already had birth before, uh, the cervical os would be fish mouth, and this is how it looks like. So we could also observe lacerations like unilateral transverse or bilateral transverse or stellate. Here is a cervical eversion and the Nabothian cysts. Okay, so in this part of the examination, we could also check for the vagina. We also have a mnemonic, a VRB, for the vaginal rugae and check for bulging. Uh, this, uh, these are done by palpation. And then as for the cervix, we check also for the consistency, the opening, position, and tenderness. As for the consistency, for a non-pregnant woman, uh, try touching the tip of your nose. That would be the consistency of a non-pregnant cervix. While for those who are pregnant, the sensation will be the same as you feel your lips, okay? So your lips would be that of a pregnant patient, and the tip of your nose would be that of a non-pregnant patient, okay? Remember that. And then next, for the bimanual examination, this is also called internal examination. One hand is inserted in the vagina, while the other hand is used to palpate the abdomen. That's why it's called bimanual. As you can see here, the patient is in dorsal lithotomy, and here the doctor inserted the two fingers in the vagina while simultaneously palpating the abdomen from left to right to be able to feel for any enlargement of the uterus, its size and shape and consistency, if soft or firm, and it would also confirm if there is any tenderness by the patient and the mobility and if there would be masses in the uterus and also the direction and the census. So the mnemonic for that is USTMD, okay? And as for adnexate, it's ATM. We ask the patient for any adnexal tenderness, the annexate, the ovary and the fallopian tube from left to right. And we also palpate for the masses, okay? And lastly, we have the rectovaginal exam. Here we insert the index finger in the vagina while the middle finger is in the rectum and the other hand is still palpating the abdomen. Okay, we do this to check for rectal sphincteric tone and if there is any recto uh, mm, and to check the rectal vaginal septum. So here now is the sample of normal findings upon pelvic examination. So in the speculum exam, we report the cervical os as pinpoint, soft, no foul smelling odor, no discharges, no masses, no erosions, and no bleeding. As for bimanual exam, the introitus admits two fingers with ease, with palpable vaginal rugae, and as for the cervix, dislocated posteriorly, tough, closed, no masses, and no tenderness. The uterus is small, located midline, anteverted, movable, and non-tender. The ecnexa has no mass and no tenderness. As for the rectovaginal exam, uh, there is good sphincteric tone, no masses, no tenderness, and there is fecal material on the gloved finger. Well, that's it. I would just like to end this lecture by remembering my patient in OB/GYN rotation. She made me realize that being appreciated by a patient gives the best feeling that keeps our passion burning in serving others. Our simple acts of helping our patients during clerkship really matters. Here you see the message of the mother that I assisted in her labor for the entire night. We walked back and forth in the delivery room, hoping for faster descent of baby Abigail. And as we walked, we were able to share life stories and got to know each other. I never did expect that she would appreciate my efforts in taking care of her during the labor watch. And I received that message at my point of burnout due to physical exhaustion and lack of sleep. My heart was really touched upon reading it. All of my tiredness was somehow relieved by knowing that someone sees my worth as a doctor, even though I am just a clinical clerk at that time. So it is very important to really care for your patient in any way. Thank you for listening. Have a good day.